But first I want to talk about what PTSD is, the effects of PTSD on family life, on work, on relationships. I'm going to talk a little bit about treatment options, so treatments including both medications and therapy, and lastly get to the resources. So you guys are probably all familiar, PTSD stands for post-traumatic stress disorder, so post meaning after, and we define traumas as basically a life-threatening event, and I'll get into a little bit more about what counts as a trauma later, and then of course the stress disorder basically just means a kind of a reaction to the stress. And as far as what causes PTSD, so with our veterans, we're often talking about military-related events. So the stereotype, of course, is combat. You know, that's the thing that we all kind of think of when we think of veterans with PTSD. But it's important to keep in mind that veterans often can experience non-combat related traumas as well. So things like training accidents. So I had one veteran who was actually involved in a plane crash in the military and was pulling people out of the burning wreckage. And I mean, that's a trauma just as much as combat is, right? So you know, people dying. And then, of course, military sexual trauma is an issue as well for our veteran population. So to spend a little bit of time about military sexual trauma. So about 20% of female veterans report rape or attempted rape during their time in the military. And that can be either from fellow soldiers, or that can be also from, let's say they're patrolling somewhere in Afghanistan and the civilians kind of grab them and pull them into a building. That could also be from, you know, if you're on leave here in the US, right, and you go drinking at a bar and you get date raped. All of those count as military sexual trauma under the VA's definition. And then not just female veterans, but also 1 in 100 male veterans report rape or attempted rape during their time in the military. And so I think it's easy to kind of overlook this and to not ask male veterans about this, but it's a really important thing because male veterans are much less likely to disclose sexual trauma because of the stigma about that, and particularly that male trauma is often male-on-male rape, and it, you know, rape is more about power and control and humiliation than it is about sex. But oftentimes, men who've been the victims of rape or attempted rape or any kind of sexual assault often have concerns about their, you know, what does it mean about my sexuality? You know, am I not manly enough to have fought these guys off, etc. So, and then we also have non-military traumas, and in the VA, we treat both military-related traumas and non-military traumas. So a lot of our veterans come into the military with past histories of child abuse. It's quite a large percentage, actually, of folks who age out of foster care, for example, join the military because they don't have a whole lot of other resources once they hit 18, you know, to be able to support them financially. And so it seems like the best bet for a career and a stable life. And then, of course, many of our veterans have experienced rape in their civilian life, car accidents, natural disasters, all kinds of things like that. I also wanted to mention sort of the last point, what does not count as a trauma? And so oftentimes it's difficult to separate out you know, trauma from other types of traumatic events. So for example, grief, you know, let's say your mother was diagnosed with cancer, and you know, basically nursed her at the end of her life. It's a very incredibly traumatic situation, but in terms of the actual DSM criteria for diagnosing PTSD, that would not meet criteria for a trauma. We would call that, you know, grief, bereavement, and you would still, of course, need treatment for that. So I'm not trying to downplay the severity of going through that, but simply to point out that you know, watching a family member pass away from a natural causes usually is a very different type of thing than PTSD in terms of the symptoms that you tend to experience after going through a grief experience like that. And please stop me if anybody has any questions about anything that I'm saying at this point. Okay. So PTSD, of course, is caused mainly by the trauma, but there are a whole bunch of other factors that go into whether someone develops PTSD. So for example, in sexual trauma, the person's symptoms are often impacted by the reaction of others after they self-disclose the trauma. So for example, do people believe them? Are people supportive? Are they able to seek some kind of justice or redress for what they've experienced? And in military traumas, oftentimes there can be what I call system failures that can kind of compound people's reactions. So let's say something happened that wasn't supposed to happen in a combat situation. It really matters how the military addresses that, whether people feel like the problem was fixed or justice happened, or whether the things were put into place to prevent the bad thing from happening again, whether people feel like they got treated fairly in the aftermath. All of those things kind of matter in terms of people's reaction to the trauma. And that makes sense, right? So if maybe someone made a mistake and that led to the death of a US soldier, right? You would want to feel like the person who made the mistake got some kind of extra training, or maybe were taken out of their position to make sure that couldn't happen again. And then lack of social support is another big factor in determining who ends up with PTSD and who doesn't. So everybody who goes through a trauma needs some kind of help getting through that. And if people have someone that they can turn to, they can talk to about what went on, they can feel supported in the aftermath of that trauma, they're much more likely to be able to kind of process that and move past the trauma rather than developing PTSD. All right. So spending a little bit of time on PTSD symptoms and what you might look for. And I know I have kind of a diverse group, but I think this stuff is, and I think it's also important to be able to figure out like what's a normal reaction to a trauma versus what's an actual symptom of PTSD. So I'll talk about that a little bit. But so the first category of PTSD symptoms are what we call intrusion symptoms. And those could be nightmares about the trauma. So sometimes people have repetitive nightmares about the event that happened, or nightmares about things that are related to the trauma. So for example, nightmares where your life is in danger, you're threatened in the same way that you were threatened during the trauma. It could also be thoughts about the trauma that just kind of pop up in your mind out of nowhere. You could just be walking down the street and boom, like something reminds you and you can't get that thought out of your head about that incident or the multiple instances of the trauma that happened to you. And the last one, of course, flashbacks. So flashbacks are brief periods of actually thinking that you're back in the trauma situation. And they're actually pretty rare. What's much more common are the first one, the thoughts about the trauma that just sort of pop up. And most of the time people are aware that they're not actually back in the situation, but it's just a very vivid kind of image or memory that pops into their head. A flashback is when you actually believe that you're literally back in the situation. The second category of PTSD symptoms is avoidance. So folks with PTSD tend to avoid thinking about the trauma. They just want to push it away, right? So it pops into their mind and they're like, no, I'm not going to think about that. I'm going to push that away. Stuff it in a box and put a bunch of chains around the box and lock the box away and just never deal with it again. I don't ever want to think about that again. They also tend to avoid talking about the trauma. So family members may ask them about what happened or what's bothering them, and they say, I don't want to talk about it. I don't want to talk about it. Stop asking. And they can even get kind of upset if you force them to talk about it and they don't want to talk about it. And then the last one, folks tend to avoid things that remind them of the trauma. So those could be certain people. So for example, for a woman who was raped, she might avoid people who have similar physical characteristics to the rapist. So she sees a person who maybe has the same hair color, the same eye color, dresses kind of in a similar way, and just wants to stay away from that person. It could also be places that remind them of the trauma. So for our combat veterans, they might try to avoid certain physical locations that were similar to where the combat took place. So for example, our Vietnam veterans, that tends to be more jungle kinds of settings. Our Iraq and Afghanistan veterans, it could be more, some of them are urban locations, like big cities in Iraq are very urban. or it could be kind of mountainous, sandy locations in Afghanistan. But they may tend to avoid even wanting to be in a place like that in the US. Even though they know it's in the US, it still makes them uncomfortable because it brings back those memories of what it was like being in that location. Folks also tend to avoid activities that remind them of the trauma. So for combat veterans, sometimes it's even handling a weapon can sometimes be a trigger. So it could be, driving is another big one. So many of our combat veterans have traumas related to IED explosions, so improvised explosive devices, and those are commonly placed along the roadside. And so, when they come back to the US, it's still sort of always in their mind, like there could be a bomb along the edge of the road. And they know that they're in the US, and they know that that's not likely, but it still pops into their mind whenever they're driving down the road. So a lot of our veterans tend to avoid driving just because of those reminders of the danger of driving back in Iraq or Afghanistan. So the third category of PTSD symptoms are negative thoughts and mood. Negative beliefs and expectations about oneself or about the world. So these are some common examples. So for example, believing I'm at fault for what happened, I'm to blame, I should have been able to prevent that from happening, I should have seen it coming, right? Kind of like the stereotypical, a woman who is raped and thinks, oh, I should have known not to go out with that guy. I should have seen the red flags, right? Like other common beliefs are things like the world is completely dangerous, other people are unsafe, other people are kind of out to get me, or not in like a psychotic way necessarily, right? But just sort of believing that other people are untrustworthy and are potentially going to put them at risk. And then negative emotions like fear, horror, anger, guilt, or shame. So just having very persistent negative emotional states along those lines. Another common symptom is loss of interest in activities. So just really not getting excited by the things that you used to enjoy doing, like hobbies, socializing, spending time with family. And then the last two impact family quite a bit. So feeling alienated from others, feeling like other people don't really understand you, other people just can't fathom what you've been through, that other people are very different from you. And then feeling emotionally numb or distant. So I've had folks say, I know I love my wife, I'm just really having a hard time feeling like I love my wife. Just not really being able to experience those positive emotions of love and caring for another person. And then the last category of symptoms we call hyperarousal. One type of hyperarousal is hypervigilance, which is basically just being constantly on guard, on the lookout for danger in the environment. So for veterans with the military training that they receive, this often takes the form of doing the same kinds of security behaviors that they were trained to do in the military and continuing to do those back here in the United States. So for example, when they arrive home at night, they might feel the need to kind of clear their house the same way that you would clear a building in Baghdad. Or they might feel the need to check all around and underneath their car in the same way that you have to check a Humvee before you get in it and you take off when you are driving somewhere in Afghanistan. Another issue is just startling easily, being very kind of jumpy. Anything can kind of make them nervous or jumpy. Difficulty concentrating is a common symptom. And that one makes sense when you keep in mind all the other symptoms that we've been talking about. So if you're constantly on the lookout for danger, that's taking a pretty big part of your mental capacity to be able to look out for danger. And so you sort of have less brain power left over to really be able to focus on what you're supposed to be doing, like paying attention in college class or doing the work that you're supposed to be doing at work. And so that can lead to difficulties with school and with job performance because they're kind of dealing with all these other things on top of what they're supposed to be doing. Sleep difficulties are a big issue as well. And that can be partially because of the nightmares, but even if they're not having recurrent nightmares, folks with PTSD can still have difficulty sleeping. It can be difficulty falling asleep in the first place, difficulty staying asleep in the middle of the night, or waking up at 4 a.m. and just not being able to go back to sleep. And for many of our combat veterans, this kind of plays into the being on guard or on alert all the time. So for example, I had one veteran who had a security system set up with motion sensors all around his house. And so whenever there would be motion, it would set off all the spotlights and alert him in his bedroom. And he had some security cameras set up as well. And so when you're constantly checking the security camera right next to your bed, you're probably not going to be sleeping very well, right? And then you can also see some irritable or aggressive behavior. And it makes sense if you would be dealing with all these things that I've talked about already, that you would be irritable, right? That you would be more likely to kind of have a short temper, that things would annoy you. When I get sleep deprived, I'm probably not the most pleasant person, so it makes sense that those things would happen. And then also keeping in mind, if we're talking about folks with PTSD who believe that, there could be kind of dangers or threats around any corner, that it may be a way of protecting themselves, right? So if their mindset is, this person over here could be a danger to me, and that person is, doing something that signifies some kind of threat, that their reaction is, well, I'm gonna do something to protect myself before they can hurt me. And then the last one, of course, is self-destructive or reckless behavior. So we often see substance abuse, alcohol or drug abuse, things like road rage, suicidality or non-suicidal self-injury like cutting or burning or things like that to manage the symptoms that go along with the PTSD. Yes?
I have a question. A lot of the things that you've been talking about sound a lot like an anxious depression. Just the severity?
Yes. That's a very good question. So that actually, I think I have a slide. So common related problems. And so there is a ton of overlap with major depressive disorder, and there's also a ton of overlap with other anxiety disorders, like generalized anxiety, panic disorder, social anxiety. So it can be sometimes difficult to tell those things apart. What you want to look for with PTSD, you should be able to see a clear increase in symptoms after the trauma occurs. If someone has just sort of generalized anxiety disorder and depression, they've probably had anxiety and depression on and off throughout their entire life. And they might have been through a trauma as well, but it doesn't seem like their symptoms got any worse after the trauma. That's probably not indicative of PTSD. Now, you can have a person who has generalized anxiety disorder and depression and then goes through a trauma and develops PTSD as well. But if that happens, you need to see a clear increase in symptoms after the trauma. And then some people think that the intrusion symptoms are the best way to tell PTSD from other anxiety disorders and depression. So for example, if you have generalized anxiety disorder, that means you're a big worrier, right? You're constantly worrying about all kinds of things, but you're probably not having repeated nightmares of that time that someone almost killed you, right? You might have nightmares about all kinds of different things with generalized anxiety disorder. You might have nightmares about how you're showing up to work, the first day of work, and you can't find the place and you're late, and then you realize you're naked, and then, it's just all this kind of like, the classic anxiety dreams that everyone has. Yes. And you had a question as well?
I have a question, I guess, or a thought. I have a number of friends that went off to Vietnam for war, and when they came home, nobody knew about PTSD.
Yes.
And it is becoming more and more increasingly, and some of them, when they go, because nobody knew what it was.
Yes.
They said go back, just like when you went to Korea or World War II, you just go back and go to work and forget about it. And I know, like, I had an uncle that went to World War II, and he came back, couldn't sleep with his wife because he was in combat all night. And she would wake up in the morning banged up and bruised, and so they finally alleviated that problem and got a small bed put sit over in corners sometimes and
Mm-hmm.
just for no reason, but they're scared that the soldiers are coming. So
Yeah.
it's not that it had to have happened yesterday or last week. Some of these guys were 20 years old.
Yes. So it's a good point about the history of it. So PTSD has been around since.
It's just that nobody knew about it.
Yes. Well, it's
They
actually.
didn't know how to treat the soldiers when they came back.
Yes. So we actually have the first recorded description of PTSD in Homer's The Iliad. And so he talks about having nightmares after coming back from the Trojan War. And so we know that this has been happening for a long time. Back in the 40s and 50s, they used to call it shell shock and battle fatigue. And the names have changed over time. But yes, so PTSD only became named PTSD in 1980 when they came out with the Diagnostic and Statistical Manual version 3, I believe. Don't quote me on that. But and so I think you're right that once we kind of formalized it as a diagnosis, we really learned more about how to treat it. So for folks coming back in the 60s and 70s, I think you're absolutely right that they didn't necessarily have a name to give it.
Or they never got treated.
Yes. I think when you don't have a name, it's really hard to treat it, right? And no one necessarily knows it's a problem. Yes, certainly. And I think your other point about Vietnam veterans, something else I should mention, is that a lot of times folks cope with their PTSD symptoms by keeping themselves just sort of constantly busy. So, for a lot of our Vietnam veterans, they kind of threw themselves into work. Like they were working 60 hours a week, they were raising their young families, they were on the weekends maybe drinking to cope, and then once they hit retirement age, we've seen a really big increase in the number of Vietnam veterans coming in for treatment because they have nothing to do all day but sit around in their empty house and think about all these things that they've been trying to not think about for the past 40 years.
Well, and they, of all people, came back and they decided to not even declare war. So it was a bad decision.
Yes. So good questions. Let me go back to, okay. So another part of PTSD diagnosis is that symptoms have to last at least 1 month. And if they last less than 1 month, there can be another diagnosis called acute stress disorder that you can give them. But it's also possible that it might be a normal reaction to trauma. So anybody who goes through a traumatic experience is going to have some kind of emotional reaction to that, right? We would be robots if we were able to just, be held at gunpoint or be raped or be in combat and just be able to sort of move on as if nothing had happened. And so one of the ways that we kind of decide, is this just sort of normal adjustment or is this enough to be diagnosable, is we look at how much of a problem it's causing in their daily life functioning. Is it getting in the way of work? Is it getting in the way of school? Is it getting in the way of relationships and friendships and having a social life? And of course, PTSD symptoms exist on a spectrum, right? So, you might have over on one side kind of, and I put normal reaction in quotes because I know that, it's really hard to say what is normal after a trauma, that everyone has their own way of dealing with a trauma. But, some folks might have a kind of a mild reaction and then they have really good coping skills and they have really good support and they have just things are set up in their life to make it easier for them to cope. And they end up getting better. And then you might have sort of mild PTSD, moderate, severe, all the way up to extremely severe. And so, I think sometimes folks, I know so-and-so with PTSD and they're so bad that they're disabled by it. They're not able to work. And then once they get their own PTSD diagnosis, they think, oh, is that what, I'm not that bad off. I must not have a problem, right? But I think it's important to keep in mind that there are levels of severity and that some people can have PTSD symptoms but have those symptoms be not severe enough to meet full criteria for a diagnosis. It doesn't mean that they're not having difficulty coping with their trauma. It doesn't mean that they don't need treatment. Of course, anyone who is having some kind of problem in their life needs treatment of some kind. Okay. And then another common related problem I didn't get a chance to talk about was alcohol and drug abuse. So in veterans, this is a pretty big problem. So it's really hard to get good estimates, but I've seen estimates of anywhere from 20% to about a third of veterans with PTSD have an alcohol or a drug use disorder. And typically it is because they are using those substances to cope with their symptoms, to kind of mask those symptoms. So, if you're having trouble sleeping, well, what better than to drink yourself into basically a coma so that you sleep for a full 8 hours. If you're having trouble coping with anxiety and guilt all the time, well then turn to some nice opiate pain medication to make yourself feel better emotionally. And so this is of course a big problem, because those substances then kind of prevent the person from coping and healing in a more healthy way. And of course those substances cause other problems in their life, which then just kind of magnifies the PTSD and magnifies the whole problem. And it can be pretty tricky to treat folks who have comorbid PTSD along with a substance use problem, because I'm sure you guys are aware, it's pretty hard to do therapy if you're using substances every day. All right. So as I mentioned before, I can kind of skip the slide because I think I've kind of already talked about it, but there is some degree of readjustment stress that is considered normal, and again, I put normal in quotes. But for anyone who goes through a traumatic experience, it's normal to feel overwhelmed and to feel stressed out, to maybe have some trouble getting along with folks in the immediate aftermath of that. Maybe in terms of family life, being distant, short-tempered, all those things can be quite common. And for veterans coming back from tours of duty overseas, they often have the added difficulty of reintegrating into family life. So if a veteran has been gone, and I know I'm using male veteran here in this case because that's the most common, but remember that 10% of veterans are female. But so if a veteran has been gone and their wife has been taking care of the kids in their absence, and then the male veteran comes home, wife's used to doing everything and being in charge and making the rules, and then all of a sudden, dad's back and he's like, wait, I get some input into this too, and they don't know the family routines, and it can just be a big source of marital conflict, as well as conflict between the children and the parents. Okay. So I wanted to spend some time talking about common misconceptions about PTSD. So maybe I should ask you guys for your thoughts or examples about this. So, we see media portrayals of PTSD on news stories. We see them on TV shows like Criminal Minds. I just watched an episode of that where they had a guy committing crimes while he was sort of in a flashback, or at least that was the story. But what kind of myths or misconceptions have you guys noticed out there, if you're aware of any?
So many people don't realize that it's active.
That it's...
They just think a lot of times that people don't have that problem, he's just acting crazy, or she's lost her mind. But
Yes.
There's nothing really wrong with her. And I think that's a fault of the media.
Mm-hmm.
Because it's just like Alzheimer's is real.
Yes, absolutely.
This post-traumatic stress is real.
Mm-hmm.
And I think they cover over it.
Sure. And you had one?
Also, I think that for a long time there was a misconception that it was only veterans that
Yes.
dealt with PTSD, and you began talking about trauma, and it's anybody that has experienced something traumatic. A child can
Mm-hmm.
experience PTSD if they've been sexually abused.
Yes.
If they've seen domestic violence in their house, they can experience that.
Mm-hmm.
Both males and females, woman or a man who has experienced domestic violence
Absolutely.
can have PTSD. Folks that have been through traumatic weather events,
Mm-hmm.
folks that have been through a
Katrina.
hurricane,
Yes.
a typhoon, or whatever, they can experience PTSD.
Mm-hmm.
Just from the fact that they went through a flood or a tornado. So I think just the idea that it was just something related to folks coming back from war.
Mm-hmm.
I think now we're seeing more and more that it's not just that trauma can,
Mm-hmm.
just having that experience of trauma can, cause someone to experience PTSD.
Yes, absolutely.
And I think there's also, it's somewhat sucked it up and went on about their lives. And they did just fine. Well, they didn't.
Yeah.
But, you know, and now everybody's got PTSD. And so
Yeah.
Well, and when they came back from World War II, the economy was in a lot better shape, which makes it easier. Well, but they hide it, but
Yeah,
it's
they were
still
hiding
there.
that.
They're all
Mhm.
hiding it. It's there.
Yes.
So they just weren't allowed to express themselves.
Yes, and we actually have some data to suggest that rates of PTSD might slightly be going up. Part of that is because people are now surviving injuries that never would have been survivable. So in World War II, you know, if you got your leg blown off in an explosion, you were probably just dead. And now, you know, we have multiple amputees surviving, which, you know, people from very serious head injuries and traumatic brain injuries surviving the injuries they never would have. So certainly, you know, it's possible rates might be going up, but I think the other side of the coin is absolutely true as well, right? That people were just simply not recognizing it. And I think in World War II as well, so many folks went to war. I think that there was more of a community feel, like everybody knew other people who were having the same symptoms. And I think that sense of community makes it maybe a little bit easier to feel like you're normal, because half of American men were over there fighting. Whereas with the most recent wars, it's been a pretty small percentage of folks to actually have gone to Iraq and Afghanistan. And so they may not, in their personal life, know many other veterans with PTSD, which I think can be a very isolating experience. Yeah. Okay, so I don't know if this has ever run across your radar, but certainly I've seen, you know, news stories and things like this that imply you know, people with PTSD are violent. So, you know, the crazy guy shooting up people, you know, and the truth is that veterans with PTSD are far more likely to harm themselves than they are to harm somebody else. So suicide is quite a common issue in the veteran population. Another myth that the PTSD is always disabling. You know, we know many veterans with PTSD can lead successful lives if they get the treatment and the support that they need to do so. And then the last, you know, myth, I think sometimes the general public who doesn't know that much about the military sometimes just sort of assumes like, oh, you're a veteran, you must have PTSD. When the truth is that many veterans are non-combat veterans. So the military needs support workers just like any big organization. You know, there are plenty of people in the military who are cooks and IT specialists, and you know, we're not necessarily even deployed out of the U.S. And only about 20% of combat veterans have PTSD, and it typically is the severity of your combat exposure. So we know the more tours of duty that you do overseas, the more likely you are to end up with PTSD. The more experiences of trauma that you've had in your life, the more likely you are to end up with PTSD. It's kind of a double whammy when folks have childhood trauma along with military trauma, because it really sets them up for you know, all of those symptoms.
That seems awfully low that only 20% of the veterans have it.
So that is an actual diagnosis of PTSD, but as I mentioned earlier, some people may be sort of just below the diagnostic threshold or cutoff, but still have some, you know, PTSD symptoms. And we also know that trauma causes all kinds of other problems beyond PTSD, right? So, you know, studies on rape victims, for example, have suggested that, you know, the majority of them suffer from depression, and that's actually the most common diagnosis post-sexual assault is major depressive disorder. And so just because only 20% have PTSD doesn't mean only 20% are having problems, right? So they may have panic disorder, they may have depression, they may have all kinds of other you know, problems that come from their trauma. Did you have a?
I'm wondering if elite groups such as the Navy SEALs
Yes.
pre-screened for early childhood or whatever, pre-military trauma so that they can cut down the rates of PTSD.
I do not know the answer to that. I do know that there's a very long selection process to becoming a special forces. And so I believe that they do psychological testing. And there is some research in the VA trying to figure out who is actually at most risk of PTSD to do exactly what you suggested. So put folks who are most at risk in safer jobs. And there's actually even some genetic research that folks are doing to see who is most at risk genetically, because we know that genes play a role in PTSD, depression, substance problems. They play a role in a whole host of conditions. Yes. So effects of PTSD. I wanted to spend a little bit of time talking about how PTSD can affect one's social life, family, work, because I think we all have, many people may have friends or family members who are veterans, or may have coworkers who are veterans, and so I think some of this stuff is helpful no matter what kind of role you're playing. So folks with PTSD are more likely to want to kind of avoid social gatherings, particularly large groups of strangers. They're probably more comfortable in like one-on-one social gatherings. Oftentimes folks kind of need to be in places that feel safe or comfortable to them, or they fear that they might flip out, is the word that they use, or term that they use. So flip out meaning like have a panic attack or get really upset, or just have some kind of negative reaction if they're in a large crowd of strangers, or they in some way feel threatened. Veterans in particular often believe that civilians won't understand them, and many of them have stories of experiencing stigma, judgmental treatment, intrusive questions. So the most common ones I hear are, how many people have you killed? Or all kinds of questions like that. And so, because of those experiences, they're much more likely to not talk to people about their military experiences, to not feel comfortable sharing that they're a veteran, or to not feel comfortable sharing that they're dealing with PTSD. And then another issue is this culture clash between military and civilian ways. So in the military, there are rules and there's order and there's a way to do things. And respect is a big issue, right? Like you have to show the proper respect to your commanding officers. I think a lot of our veterans, when they get out of the military, they feel like civilian life is just very chaotic and people are disrespectful and people are, incompetent and, they're not doing things in the right way, right? The structure, yes, exactly. And I think also in the military, go ahead.
I would say that about the culture clash. I work at a community college, and I've worked with several veterans over the years, and there was one gentleman. He was a great student. Was on his way to completing his first 2 years of college on his bachelor's degree. But he had an interaction with someone, and he felt that was disrespectful.
Yes.
And he went about it to explain to them about, he had served in the military and how respect, he's earned respect, and he's paid his dues and all. And it got pretty heated. And,
yes.
I spoke to him about it, and I understood where he was coming from. And that, sometimes when you talk about that clash, sometimes they're still there. Those rules of the military and how that's ingrained in them and everything. And then coming back to, like a college setting or
yes.
a job setting or whatever, trying to bring that down sometimes is difficult for them because
yes.
it has been ingrained in
yes.
them.
Right. When you join the military at 18 years old, right, and that's your whole formative, early adulthood experience, that's your idea for how the world works. And I think there are many benefits to it, right? Like, I mean, I would like it if everyone were more respectful. And so I think, it's...
I think our society has dipped down too.
And what it was that he passed by somebody and they had their music up really loud in their phone, and the music was derogatory. Rap music that was really derogatory. And he said, hey, you don't, not in here, we're not going to...
Yes.
You're not the owner of this place. You can't go around and tell people.
Right. But in the military you can, right? Like, if you've got the right rank, you can tell anybody anything.
Maybe we should be like Israel. Everybody has to serve 2 years.
All right. So I have some pieces of advice for basically for friends of veterans. And some of this applies to veterans with PTSD. Some of it can apply to any veteran. So the first one, don't ask personal questions about their military service. If they want to share, they'll share. You can ask general questions like what branch of the military, or when were you in, or things like that any friend would ask. And don't ask personal questions about mental health unless they bring it up. Of course, unless you are a mental health provider, which is a whole different ball of wax, right? But I think the same kinds of rules apply in terms of being sensitive about how you phrase things. Because even if you are a mental health provider or a professional working with veterans in a nonprofit or something like that, you still have to be very careful, that you're not asking things in the way that might seem, intrusive or stigmatizing, or that just make them feel like you're a civilian who doesn't get it. The next piece of advice: don't say, "I know what you're going through." Even if you have been through a traumatic experience in your own life, the first thing a veteran is going to say to you is, "You have no idea. If you have not served in combat, you have no idea." And so that can often come off as kind of dismissive if you say, "I know what you're going through." The next one: don't give unsolicited advice. So if you have a suggestion for a friend, maybe phrase it as things like, when I struggled with depression, here's something that really helped me. You're sharing something personal about yourself. You're not necessarily telling them what to do to fix their problems. And then keep trying to be a friend. So, and this applies for anyone, right? So folks with depression often don't feel like socializing. They may turn down social invitations, even though they still want to be your friend. And so, the advice is keep trying to be their friend. Invite them to one-on-one get-togethers, or say, when you're feeling better, I love to hang out with you. I think a lot of clients that I've worked with have kind of accidentally burned bridges by turning down invitations to go places, and then the friend stopped asking because the friend sort of figured, oh, if you wanted to be my friend, you'd say yes. And that's not always the case for folks who are struggling with depression, anxiety, or PTSD. All right, so effects of PTSD on family. So veterans often refuse to discuss the traumatic experiences with their family members for a couple reasons. One, they fear that their family members will reject them. If I tell my wife how many people I killed, she's going to think I'm a monster, right? If I tell my wife about this, she's going to think I should have saved my friend. They also tend to feel like a burden to their family members, particularly if the PTSD is causing any kind of difficulty at school or at work. They feel like I'm supposed to be the strong one. I'm a Marine, for God's sake, right? I should be able to power through this and take care of my family. And what's wrong with me that I can't do this? They may also be overprotective of their family, particularly combat veterans who've seen all kinds of dangers. They have in their mind what bad things could happen. And so let's say with children, right? Like the teenage children, they want to go to this party at so-and-so's house, or they want to go to this, who knows, right? And the parent's thinking, no, that's too dangerous, you can't go there, I need to be constantly checking in with you. And that can cause conflict with the children, right? And, why are you so strict? What's wrong? Why are you acting this way? Veterans often, or veterans with PTSD, I should say, often are more emotionally distant from their family, and can have, as I mentioned before, all of these symptoms can cause difficulties with parenting, difficulties in the marriage. As we know, PTSD can cause more irritability, and so you can be more irritable with normal child misbehaviors. As we all know, misbehaving is a normal part of childhood, and we all just have to kind of figure out how to deal with it. But if you're struggling with all these other symptoms and issues,
Between 1 and 12, and then pick back up at 3.
yes. And then also wanting things done the military way can sometimes interfere with family. Like you want your 8-year-old to make their bed in the nice military way that you're supposed to make your bed. They're not going to be doing that, right? And so kind of the culture clash happens in families as well. And all of these things often make spouses of military members feel rejected by the military member. So if the military member is not sharing anything about their mental health, about what they went through, if they're being more distant, if they're kind of pulling back a little bit, oftentimes the spouse feels unsure of whether the military member loves them or cares for them, and of course that can cause all kinds of problems in the marriage as well. Yeah, I was kind of mentioning that already. So the effects of PTSD on the family. So the family members often feel rejected. Why won't he just talk to me? Why won't he just tell me what's going on? They often feel confused. So things like he's not the same man I married. He's not the kid I raised. I don't know who this person is. And then, as I mentioned before, often feel that the routine they developed while the veteran was deployed is disrupted now that the veteran is home. And family members often want to help but don't know how. And I think a struggle with where is the boundary between helping and enabling, right? So, if they're struggling with their mental health right now, is it appropriate for me, the spouse, to take over and do more household duties for them? To some degree, yes, but if you take over and do everything for them, is that actually helping or is that not helping? So I think that's another great place for both mental health and community providers, to be able to support family members to figure out, how do I help? What do I do? What should I not do? And then children, of course, may act out, may be distant from the returning service member. Children have short memories. If you're deployed for 6 months, it can feel like years in the mind of a 5-year-old. Okay, so for family, advice for family, don't pressure them to talk. Let them know that you're available to talk if they ever want to. Don't take it personally. So we talk about separating the PTSD from the person. So, if they've had a panic attack and they just need to walk off, take a break, be alone for an hour or two, right? Like, don't take that as a rejection of you as a person. Like, they just need some time to cool off. Doesn't mean that they don't love you. It just means that they can't be around you right now. Again, don't say things that could be perceived as judgmental. Let them know that you care about them, that you're there for them. And if you don't know how to help, ask, right? I think that's good advice for any family member of someone struggling with mental health issues. And then, make a plan for triggers. I haven't really mentioned that word here. You guys know the word trigger? Okay. So triggers being anything that kind of reminds you of the traumatic event. So for, let's say, a rape survivor, a trigger could be the smell of a particular cologne that the attacker was wearing. And every time she smells that cologne, it just brings her right back to the event itself. And so family members can be helpful in terms of making a plan to cope with triggers or to cope with overwhelming situations. So for example, I've had family members where they're doing a family trip to the mall to go Christmas shopping, but they've kind of discussed ahead of time that if the veteran becomes overwhelmed, that they have, it's totally okay for them to just sort of walk out of the mall, go sit in the car, calm down, and that's sort of a pre-understood arrangement, right? That no one's going to get upset that they're bailing on Christmas shopping, and that no one's going to take it personally. And they will either come back when they feel calm enough, or that they will just sort of wait until the other family members are done shopping. And then, of course, convey your belief that they can recover, right? So there's actually some research, some very recent research, it's not published yet, but it suggests that one huge component of whether a veteran sticks with treatment is how supportive their family members are of them being in treatment. If they have told their family that they're going to therapy or treatment, and if the family has said anything positive or has said anything negative about being in therapy or treatment, that those are huge factors that play a role in whether people stick with it. We know that family is key to recovery. So I wanted to spend a little bit of time talking about treatment. I'm just checking my time here. So the first step for treatment, right, is making the decision to seek treatment. So we know that reluctance to seek treatment is common for folks with all kinds of mental health difficulties. So it often takes the form of various beliefs. Beliefs like, there's nothing wrong with me, I'm fine. Every veteran has these problems, I'm normal. If I admit I have a problem, that would mean I'm weak, that would mean I'm crazy, that would mean I'm a failure. Seeking treatment is not manly. I'll get fired if my boss says that I have PTSD. Medications will turn me into a zombie, or civilian doctors won't be able to understand me. I've heard every one of these from patients of mine. And so the very first step is overcoming some of these beliefs, right? Helping veterans to see why it might be worth seeking treatment, even if they're afraid of these things, or maybe helping them to see how some of these things may not always be true. Okay. So the next step, of course, is treatment options. Now, I'm not a prescriber, so I'm not going to spend much of any time talking about medications, but I think it's helpful just to have a brief overview. Most common medications for PTSD are anxiety medications that are SSRIs, so things like Zoloft, Paxil, Prozac. I think the only two that are FDA approved for the treatment of PTSD are Zoloft and Paxil. Also, sleep medications can be helpful. Things like Trazodone is the most commonly used one in the VA. Of course, other sleep medications exist like Ambien and Lunesta and things like that. And there's also a medication that helps a lot with nightmares. It's called Prazosin, or also known as Minipress. And it's basically a blood pressure medication that you take right before you fall asleep. And so I think it helps I don't actually know because I don't know that much about the pharmacological part of this, but my understanding is that it kind of helps your body calm down while you're sleeping and kind of regulate your physiological arousal so that your body is calmer and then you have less nightmares during that night. We're at the VA, we're very careful about recommending any kinds of medications that could be potentially addictive, things like Klonopin or Xanax. Any kind of benzodiazepines have a big addiction risk, and we know that the last thing you want when you have a mental health problem is for us to give you a medication that causes an addiction on top of that mental health problem that you already had. Another good reason we don't give Klonopin or Xanax is because there's no evidence that they help over the long term. So they're really good for short-term anxiety, right? Like if you have a biopsy coming up, right? Like, yeah, sure, you can have some Klonopin right before you get your biopsy done, right? But if you have PTSD and you're talking about taking a medication daily for the rest of your life, you probably don't want it to be a short-term kind of medication. Other treatment options are things like support groups through vet centers, through community groups. I know a lot of faith-based organizations offer support groups. And things like colleges often offer veterans groups and things like that as well. VA, we have peer support. So it's a new kind of initiative within the last few years as we've hired people who are veterans themselves who have had a mental health issue and are in recovery from that issue. They are full-time paid employees at the VA, and their job is basically to help talk to veterans about why to seek treatment, talk to them about what resources are available, talk to them about their own story, right? Like, I had the same concerns, but I gave it a try, and it helped me. So I think it can really help with stigma, and as well as just kind of having someone to talk to. Okay, so this graph is about how effective medication versus psychotherapy is. So this is from a large meta-analysis, which is basically a study that combines a whole bunch of individual studies. So the numbers up here are what's known as effect sizes, but it's basically how much better it helps you get. So medication helps folks get better with PTSD. But psychotherapy is actually more effective for PTSD than medication is. Now, I'm not trying to bash medications. I think that they're a wonderful tool. And oftentimes folks might want to start on a medication to kind of get some of their symptoms under control so that they can do therapy, because therapy is not a quick fix, right? So the medication will help you get things under control in the short term. And then you work on the therapy to fix kind of the longer term issues. So there are 2 first-line evidence-based psychotherapies, and they should be available at all VAs nationwide. And both have an approximately 80% success rate, so about 80% of patients get some better. It may not be all the way better, right? And so a realistic picture of what better looks like might be, you know, we're happy if you get 50% better or 80% better or 90% better. I don't know that 100% better, never thinking about the trauma again, is a realistic maybe option, right? But if you're coping 80% better, that's a huge win in terms of how it affects your life. And treatment may initially kind of kick up some symptoms. So for example, if you have been avoiding this and never talking about it for 40 years as a Vietnam veteran, and then you come in and tell someone the story of what actually happened in Vietnam, you may be kind of distressed, right? Like, I've had to talk about this, which I've tried to keep buried for a long time. But that's not a sign that treatment isn't working. That's just a sign that, you know, you're working through what you need to work through to get better in the long term. And as I mentioned before, veterans stick with treatments a lot better if their family is involved and supportive. So I want to talk about the 2 evidence-based psychotherapies. The first one is known as prolonged exposure. Has anyone heard of prolonged exposure before? Or? No. Okay. So prolonged exposure actually was developed by a lady named Edna Foa, who is a psychologist from Israel. And she actually developed it with rape survivors and then applied it to folks who were veterans from the conflicts over there in the Middle East. She now is in Philadelphia. And has worked with the VA to help us implement this treatment in our VAs nationwide. So prolonged exposure really targets the avoidance that is characteristic of PTSD. So folks with PTSD, as I mentioned before, may avoid all kinds of things, right? They avoid talking about the trauma. They avoid situations that remind them of the trauma. They avoid thinking about the trauma. And so here's an example. Let's say I tell all of you to sit in this room for the next 5 minutes, and whatever you do not think of white bears, right? Just sit here, do nothing, but don't think of white bears, no matter what you do. What are you going to do? Think of white bears, right? And so the more that you try and push it out of your mind, right, the more it kind of pops back up with a vengeance. And it says, I'm here, you need to deal with me. And then the same thing happens for avoidance in daily life. So if you're avoiding any situation that might possibly remind you of the trauma that you went through, it's really easy to start avoiding lots of things. So you might avoid crowded places, and you might avoid going to stores that could be crowded, and you might avoid driving, and you might avoid, and the list just goes on and on of all the places that you avoid. And so prolonged exposure really targets stopping the avoidance and pushing yourself to practice going into the situations that you would typically avoid and coping with them in a healthy way rather than avoiding them. And so we know that when we face our fears, it's really the only way to get over our fears, right? So, you know, I have a small child who was once afraid of swimming. I don't know why. He had no traumatic swimming-related experiences that I know about, but he was just afraid of the swimming pool, right? So he would cry, and I would say, okay, let's just sit on the edge of the swimming pool and like put your toes in, right? Like, that's all I need you to do right now. He would put his toes in, he would be nervous, he would be holding on to me. I'd be like, you're okay, it's okay, right? After maybe 10 minutes of putting his toes in, I was like, okay, well, let's scoot you down a little bit more and get you up to your knees. And he would be anxious, he would be nervous, he would get used to it after a while. And so it's this idea of kind of working your way up to doing the things that you're afraid of. And over time, your anxiety goes down, and you habituate, which is the word that we use. But basically, you get used to the situation. You can prove to yourself that it's not actually realistically dangerous. The situation might have been dangerous over in Iraq or Afghanistan, right? Like driving a vehicle was realistically very dangerous over there. Driving a vehicle over here is only minorly dangerous, right? In Houston, maybe a little bit more than some other places, but certainly far safer than it was in Iraq. And so the experience of kind of working your way up to driving can kind of prove to your brain that driving is actually safe, that you can handle driving, that you can cope with driving. And over time, your anxiety about driving will go down. And so this is not something that we recommend people do on their own. You know, they're walked through this process with a therapist who teaches them coping skills and helps them come up with a list of safe activities and a way to kind of target them very systematically from the easiest activities, working their way up to the harder activities. And prolonged exposure also involves repeatedly telling the story of the most traumatic event so that they can emotionally process that event. So oftentimes folks have not talked about the trauma with pretty much anybody. If you don't talk about the trauma, it's really hard to figure out what the trauma means to you as a person. It's really hard to figure out how you feel about it. It's really hard to kind of come to terms with what it means for you. And so talking through it is one of the best ways to do that, even if it's uncomfortable. Any questions about this treatment that I talked about? Okay. So the next evidence-based psychotherapy is something called cognitive processing therapy. So cognitive processing therapy really targets the negative beliefs or the negative thoughts that people have about the trauma. So for example, I should have seen that ambush coming, right? Like I should have seen the signs. And they really believe I should have seen the signs. But when they believe I should have seen it coming, what effect does that have on them? Negative, absolutely. Because they
could have prevented it. They were gone.
Yeah. So then they blame themselves and they feel guilty and they feel like, you know, maybe I'm, you know, I should have seen it, I failed, maybe I'm a failure as a person, right? And they maybe even generalize it to things outside of just that one situation. And so one of the things that we do in cognitive processing therapy is identify those thoughts that are keeping people stuck, and we examine whether those thoughts are actually true, whether those thoughts are helpful. So for example, we might ask our clients things like, well, is there any evidence that that's true? Is there actually any evidence that you should have seen the ambush coming? Did anybody else see the ambush coming? No? So then why were you the one person who should have seen it coming when the 20 people with you also didn't see it coming? You know, sort of helping them figure out what things that they're telling themselves are inaccurate, unhelpful, and are keeping them stuck. And this is actually a form of cognitive behavioral therapy, if anyone's heard of that before. CBT.
Is it a form of CBT?
Yes.
Because it sounds like it.
Yes, it is. Yes. Okay. All right, so there's also some forms of family treatment for PTSD. So at the VA, we sometimes run family education groups to educate them about PTSD symptoms, how they might be helpful to their family member. We also offer couples therapy to help with marital difficulties. And then sometimes we involve the spouse in the veteran's own individual therapy for PTSD. So this book, Cognitive Behavioral Conjoint Therapy for PTSD, basically involves the partner sitting in on the therapy session so that they can learn some of these tips and techniques as well as the veteran.